and I will try to make it as brief, as clear as possible. I have no disclosure, not yet. Therefore, to start with, when we talk about recurrent implantation failure, while I was in the US, they told me that back in the 80s, they were believing that 80% represented RIF. So it's mostly an issue of what do you achieve, what is your performance, and therefore, when you fail, you believe that's the problem of the patient. Starting the efficiency of IVF that started around 12% back in the 80s, every advancement that has been made has changed this. So, for example, when we went to day 3 embryo transfers, then we used software embryo catheters, then we used ultrasound, of course, then we started to do hysteroscopies to check for other pathologies. Then we started to assess the endometrial thickness in about the 80s or something like that. And then we went to blast transfer that increased by at least 15% our outcomes and so forth. Freeze-all changed everything again. And of course, PGTA, we discussed it yesterday anyway, it probably increased some kind of pregnancy rates, but in the end, success has changed, and the notion of ART success has changed. So right now, if we have like 50% success, we are happy, but this was not possible back in the days. Although, with this being said, you still have about 30% embryos that never implant, although you euploidy check or whatever. So the question is, what actually is RIF? Well, if you would look on PubMed, because that's our Google, unless ChatGPT will change that, we're going to find 78 different definitions. And therefore, there is only one that actually sticks and sticked so far, was the one from Cochrane that dates in 2014, saying that you either have 3 failed embryo transfers or 4 blastocysts transferred. That's going to fall. Sorry, the table is falling. Okay. Therefore, this represents recurrent implantation failure, but as you can see, there is no mention of age, and we all know age is very important in IVF success. Also, if you're going to look to those papers, you're going to find several potential causes, starting with uterine factors, male factors, lifestyle factors, immunological factors, infections like endometritis, endometriosis. But none of these studies will tell you what actually RIF is. They will say, well, it's most likely it will cause RIF, but no one actually knows what RIF is as a definition. And actually, we don't know what evidence we need to be compelling in saying RIF is that or otherwise. So, as mentioned, RIF is a very complicated scenario. Although there are many publications, it's very difficult to understand what RIF is. And I think in terms of diagnostic, it's very surprising that all of these studies that were done so far never consider age as a cofactor, although we always say that the potential outcome of ART success is based on age. In terms of research in this scenario is that if we cannot define something uniformly, how can we begin to research the disease? So if you don't know what you're looking for, how can you recognize it? In terms of clinical work, well, if you cannot research a disease, how do you study its prevalence? And also, how do you assess the literature or the efficacy of treatments on it? Because if you just move your cutoff a little bit, it changes a lot in terms of conclusions. So therefore, the status of today, the scenario of today, the Napolitan theater of today, is patient requesting intervention that lack evidence, just because they look online or whatever, clinicians that are prescribing non-validated treatments because they are fearing failure, and then you have investigators that lack a baseline fundamental for research. So therefore, we need to update the definition. Dado actually helped with that, which is present here, because we all actually know that deep down, maybe we don't say it, that Xavier actually told me yesterday, we don't say everything we believe. Chromosomal abnormalities are probably the most common cause of failure. Of course, you can have endometrial factors, that's for sure. We never said otherwise. And there are different papers saying receptivity matters, other endometriosis matters, and immunological and so forth. But the reality is that what we know so far is that even when you transfer euploid embryos, you do not have 100% success. And that's because probably human reproduction is very faulty. not that efficient. And therefore, depending on the lab, the clinic, you have a range from 43 to 77 when you have euploid embryos. So therefore, not all euploids implant. Then the cause, what is RIF? Well, the question is there a persistent endometrial factor that actually prevents embryos from implanting? And this is actually what we wanted to try to prove first, before getting to the Lugano consensus. What happens in patients that have successive euploid embryo transfers? 3, my paper, and then they had the 4th and the 5th. This is the first paper, 2021, where actually we looked into 4,429 patients. At that time, we excluded all those patients with endometrial thickness less than 7, but we included all patients with a normal morphological cavity, uterine cavity, and with euploid embryos. So when we looked at the results, after the first embryo transfer, the implantation were around 70%. After the second one, 60%, and after the third one, you have 60% again. Now, of course, like in any clinical ART setup, you're going to have patients who fail, patients who drop out, patients who have remaining embryos, and patients who have to do a new IVF treatment to get new ones. Therefore, we had these 2 groups here in which we calculated again, and the implantation were around 60% the same. And LIBOR rates were actually according to what we have achieved in implantation rates with the miscarriage rates that are commonly known in PGTA cycles. Now, if you look into a Kaplan-Meier estimates evolution, you're going to see that actually in the end, 95.2% will have sustained implantation rate, I mean embryo ultrasound at trimester 1, and 92.6% will deliver. With this being said, we actually stated that patients who failed do not have an increased risk of failing again if you do the second or the third one. And if that's the case, it means that there is no persistent endometrial factor, because if there would be one, your implantation rates will go down. Therefore, our data really put into the question the uterine factors, a persistent uterine factor. So this was our findings, that true RIF is rare when you have euploids, embryos, and that 95.2 will implant. And of course, implantation rate declined minimally, and actually additional euploid embryos will probably offer a hope for a better outcome. So if you look at our line, we're going to have an estimate of 5%. That's what we said, less than 5%. Because at that time, it was very difficult to say even less. People would have freaked out. So we looked into the US database in SART, and we tried to look for a similar model, whereas they had successive euploid embryo transfer, and we found 2 successive embryo transfer in about 70,000, more than 70,000 patients, and actually their delta was 6% between the 2 embryo transfers. So it was not an increased, how can I say, a substantial decrease in implantation rates, as you would expect if you were to have a persistent endometrial factor. And then, actually this happened after the Lugano paper, because in that meeting we talked about what would happen if you would have a 4th one or a 5th one. It was natural pondering about it. And therefore, the paper came from the, thanks to KKR funds that actually grouped all these big clinics, and they had gathered together 122,000 patients, and they showed that with the 4th and the 5th, implantation rates stay very high, above 50%, and actually RIF in the end is more than 2%, is less than 2%. And this is a paper in Human Reproduction, and it shows that actually after 5 successive euploid embryo transfer, 98% of patients have a child. Now, of course, the question is, and I try to put this here because it's very important to understand how you will increase your cohort. So if you were to have, let's say, the blue population here, this is your RIF population. If you have 5% of your population that have RIF, these patients will never get pregnant, never, because they have a problem with the uterus. The question is, if you go to the second one and the third one, this population will be enriched. And by default, this means that your 4th embryo transfer should not be able to give you statistically more than 24%, because that population that remains is enriched every time by those 5% that never get pregnant. And that's never been reported because we have above 50%. So Also, in the literature, you're going to find 10%. So we try to represent graphically that too. So the 5% is green, the 10% is 10. This is how the line would look like if you have, let's say, 5% or 10%, because you can have papers that will hypothetically tell you what reef should be like. And this is the decrease. Well, if you put the data that we reported, this is the blue line. So therefore, when we actually, this is the data that we published for the fourth, and with the data from the EV group, in the end, it's even less than 5%. But it was very difficult for people to accept that. So probably around, between 1 and 2%. And 2023 was a great year for RIF, because you had the Lugano paper that came out and the ESHRE paper, the guidelines for clinical good recommendations. These two papers, although they appeared more or less in the same time, the Lugano was in February, the ESHRE was in June, they looked at the topic of RIF very differently. First of all, the Lugano consensus workup looked to find a definition. What is RIF? And also was to set up the basis for research. If tomorrow you're going to do an RCT on RIF, tell me what will be your cutoff. It will not be 60%, because then you're just going to waste 5 years of your life looking for something that maybe is not even real. So it was very important also to provide for researcher a common ground to build research, because probably there are patients that will fail, but you really need to do research profoundly to understand why they fail. And of course the diagnosis, and we took as a cutoff, as in any research, 95%. I think Professor Somilana proposed 95%. No? Yeah. And the actual recommendation, they looked into a threshold of 60%. They published in Hymen Production, and they looked for clinical, what should you recommend to your patient in clinical practice. As the difference start building when you decide what groups you're going to use, because we in Lugano consensus, we actually used the SART group, the American groups, where we split it 35 to 37, 38 to 40, where the ESHRE group turned to 35, 39. Well, we believe that was wrong, because if you see here, known aneuploidy rate is 30% for those of 35 to 37 and 50% to 38 to 40. So it's almost double in terms of euploidy rate. Therefore, it cannot add up. Also, the Lugano recommendation were based on the idea that if you get 95% with 3 euploid embryos, we calculated the number of untested embryos, because not everyone will do PGTA, and as we saw yesterday, we are very far away from that to be happening. Therefore, we needed to actually make a model that will try to orient patients and people on the length of the journey. For example, a woman that is younger than 35 will need 4 blastocysts to get the 95% statistical chance of implantation rate. Where, for example, a woman above 40 needs 13 to 27 embryos in order to get that live rate. So for us, it was very easy once we have these groups defined. In terms of the extra clinical recommendation, the problem appears that, for example, in terms of euploid embryos, they would actually intervene after the second embryo transfer. But as you can see here, 2 euploid embryos will be 90%, and then it will be 87% and 82%, where the cutoffs is 60%, it is obtained for the first one. So in the end, we kind of had a big difference in terms of perception. And as you see here, when we looked at that table that was shown also earlier by my previous speaker, it's not very consistent, because the 60% is sometimes appearing after the 3rd embryo transfer, and then sometimes it appears after the first one. And therefore here, after the 3rd one, although they say to intervene after the 4th one, they choose 59%, whereas here is 67%. So it's very difficult. And also, if you would to read the paper of Rosenberg, they also propose 80% as a cutoff. Anyway, we all know it's difficult to make people agree. I had a chance to have a group of 27 experts that actually agreed from the first minute. And I highly suggest you read that paper. And this table was meant and designed for people to use in terms of when you see your patient, to try to explain the length of the journey. For example, if you take a plane from Milano to Paris, and I'm going to tell you it takes 2 hours, For 2 hours, you're going to be seated in your seat very nicely. You're not going to ask question, are we there yet? Okay? But if, for example, the flight is 3 hours or 4 hours in, and you know it's 2 hours, then you start to get worried. I think our patients come with the same idea. They come in, they believe they will get pregnant on the first embryo transfer, and that's very far from the reality. And therefore, this anxiety will actually be transferred to the doctor, and then we do the add-ons. So the add-ons that actually the ESHRE and the Lugano consensus agree upon, all these add-ons that are mentioned here have no proof of efficacy. Therefore, so far, no one can actually justify the use of those. Although probably most of you use them, there is no proof of efficacy that this has to be used in treating RIF, although RIF probably does not exist or is very low. So it's very important to know all this because this is a very French paper where it's probably one of the countries that has a very free ART care or IVF care, where dropout, although in most countries is believed to be financially driven, actually in France, 1 in 4 patients will drop out if doing IVF treatment, although it's free. So it's a problem of communication and a problem of perception. And it could be that we as medical providers are incapable of describing to the patient the length of the journey. So in terms of recommendation, because this was the common goal, we agree, the Lugano and the ESHRE guideline agree on many things. First of all, your medical history, physical examination, AMH, ovarian testing, and so forth. So your workup should be as complete as possible from the beginning of your first embryo transfer. There are a few points where we don't agree in terms of what you should do in terms of follow-up. So for example, here, there are things that are recommended by the ESHRE group, like hysteroscopy or chronic endometriosis testing or thyroid function testing. I would ask why not do it from the first time you see the patient, because you don't need to fail an embryo transfer to test for the thyroid function. I mean, adding TSH to your blood work, that is not that complicated or expensive. For example, doing a 3D ultrasound, is it that complicated? Should you wait to fail an embryo transfer before you do a 3D ultrasound? Hysteroscopy is a different story, but I'm in Italy, so I don't want to go there. We all agree on things that should not be used, so they are not recommended, like vitamin D testing, microbiome, NK cell testing, cytokine, HLA, sperm DNA fragmentation. I'll go rapidly. So there are several also things that we agree upon on terms of what you should do if you find RIF. For example, reviewing estradiol treatment if endometrium remains thin, genetic counseling, lifestyle factors. But there are a few things that should be considered. For example, antibiotics if you find endometritis. Well, if you find endometritis, how can you ignore that and not treat it? I mean, should you fail an embryo transfer before you treat it? And also, why not just do a blastocyst stage transfer? And I'll just keep going. PGTA is not a question, but we are again agreeing upon what should not be doing. Like, for example, vitamin deficit treatment, scratching, PRP, assisted hatching, intralipid, whatever, you name it. There are so many things that we are proposing to our patient that are completely lacking proof of efficacy, and everyone agrees they should not be performed. So there is no debate about it. And we agree that for all patients, we have to be very empathic. We have to listen to them, their feelings. We have to show respect for their problems. And we have to be honest about the process, the outcome, and the prognosis. So probably that table that I just showed you, you have to tell them. A woman of 40 years old age cannot get pregnant after 1, 2, or 3 embryo transfers. If they do, well, it's just great. We will be happy for them, but most will not. And therefore, it does not justify the use of add-ons in this case. So we have to be very compassionate about it and empathic about it. In conclusion, I think true recurrent implantation failure is extremely uncommon, unexplained, is not when you have an Asherman syndrome and you are shocked, or you have a big myoma in the cavity and you are shocked. I'm talking about a normal morphologic cavity that you have checked by 3D ultrasound or hysteroscopy. So in these cases, recurrent implantation failure occurs in less than 5% of infertile couple. Defining RIF needs a global effort. Europeans alone or Americans alone are not possible because infertility is a global problem. So you have to take everything from everyone's experience and put it together and try to see what it brings. Reassurance and continued conventional therapies are warranted in most cases. We don't have to reinvent the wheel in this case. It will seem reasonable not to assign the diagnosis of RIF to a patient until she has fed at least 3 euploid embryos, or in those cases where we don't do PGTA, the equivalent number of unscreened embryos adjusted to the age. Age is very important. And of course, current add-ons should not be used in patients that are suspected with RIF. And I think that probably the most important message, try to do the best infertility workup before starting to transfer embryos, because it will help you probably avoid failures more often than you think. And these are the 2 teams with which I work with in Army, New Jersey, with Richard Scott, and in FOSH team with Professor Ayubi and Professor Dizigler. Thank you very much for your attention.